Okay, salam alaikum. Good morning, distinguished chairman, Dr. El Reyes, Dr. Omer, scientific committee. Thank you very much indeed for this kind invitation. And it's a real pleasure to be back in the yard amongst friends and to see so much passion for ultrasound also. So yesterday we were treated to a wonderful workshop in spondyloarthropathy and the axial SPA. Today I'm going to shift our focus to peripheral enthesis. And in part, this is going to be the story of my journey in exploring this area. And I will tease you a little bit as we go through this journey, because these are the things that I thought of. And hopefully, you will enjoy this as I go along. So I think when I started ultrasound and we started seeing things, the first question I asked to myself was, what exactly is an enthesis? You know, and as fellows, we were taught what enthesitis is, but we were never taught what are entheses. And if you think about it, there are a ton of connections to tendons and muscles to bone. And the question is, why do we get enthesitis in places that we do? You know, it doesn't, how come all our body doesn't all suddenly come down with enthesitis? Or even if we look at the face, I know the smart ones among you will say, yes, you get uveitis, but apart from uveitis, how come we don't get enthesitis to the face? So this was one of the first questions I asked myself, and it turns out that there are two distinct types of enthesis, and they're membranous enthesis and fibrocartilaginous. What do I mean by that? So membranous entheses are where tendon fibers are mummified into bone, and these are called Sharpie's fibers. And then there are other entheses where you have tendon fibers in a zone of fibrocartilage, and that actually joins into bone. So the next question is, why do we have these two types of entheses? And they're very different, and it turns out that enthesitis tends to occur at fibrocartilaginous entheses. So the fibrocartilaginous entheses are area where the tendon has to excurse through a much more range of motion than membranous entheses. So because of that, and this is a theme I'm going to amplify during my talk, there has to be a shock absorbing mechanism. And if you just had everywhere had membranous entheses, you would end up ripping your entheses or tearing your tendons. So the fibrocartilaginous entheses, the body developed because of this shock absorbing system that it wanted to develop. So the next question will be, okay, so big deal. So why are you talking about enthesitis? Why is it important? And because we had such short time, I limited myself to psoriatic arthritis. So when you look at registry data, enthesitis does occur up to 50% of patients in various registries. And it's fast emerging as a marker of disease activity, and it also correlates quite well with clinical symptoms. Now, we just recently did a review where we looked at a whole bunch of placebo-controlled trials that used drugs. And we saw in these trials, using various different methodologies, that the majority of them had a prevalence of enthesitis of above 50%. So it does occur quite a bit. And we also feel in the imaging world that the disease starts first in the enthesis and then goes to the joint. So it ties in very well. And it also turns out that this is now an important domain for us to consider when we think about therapy in psoriatic arthritis. I personally like the GRAPPA guidelines rather than the newer ACR guidelines because they're very logical and they make you think which of these domains are more dominant and which of the therapies you might pick might cover most of the domains that matter to the patient. So very logical, and enthesitis tends to be one of the main domains. So the next questions we'll ask ourselves is, okay, now we know enthesitis is important, but how do I measure it? And how do I measure it in psoriatic arthritis? Well, from the world of the ankylosing spondylitis or axial SpA, we have a variety of indices, which first started with the Mander index. If you remember, Mander was a really unfeasible index with a whole lot of things to press, and this was quickly dispensed with. And people came up with these predominant entheses, the Massey's instrument, Berlin Spark, etc. However, for psoriatic arthritis, except for the Leeds enthesitis index, we don't really have any specially constructed one. And it turns out that people, mostly in clinical trials, are using the Massey, Spark, and LEI. Now, one of the problems with the clinical indices is that we're just mashing or pressing on a point and saying, is it tender or not? And it's very crude. So we have no idea what goes underneath the skin. Is there inflammation at the enthesis? Are there chronic changes at the enthesis? Is there any damage? So all this information we don't know clinically. And all we know is when there's no pain or no pain. So this is where I think we as imagers come in, and we have a lot of interest in seeing what is occurring underneath the skin and try to identify are there patients where you have discrepancy between pain and enthesitis, and we'll talk about in a second. Similarly, in ultrasound, there are many different scoring systems, but luckily for us, there are two that are popular, the GUESS system and the MASI system. The GUESS system didn't have Doppler ultrasound, and this is where the MASI improved on the GUESS system. There are a few other methodological differences, but it also included Doppler and included the triceps. And you'll also look at all of these entheses do include the biggest tendon in the body, the Achilles tendon. So luckily for us, these two are the competing major entheses used in most studies. Okay? And the kind of things that we see structurally are things that we covered in a workshop yesterday. When tendons or ligaments get diseased, they will show very common themes. They will become thickened, they'll become disorganized, there'll be neuroangiogenesis, and there'll be neurovascularity. And this is partly tricky because some of this neurovascularity, as I'll talk in a minute, is due to repair mechanisms, not due to inflammation. So this is where our challenge starts coming in, how to differentiate normal repair mechanisms to what happens in inflammation. So once we start getting these changes, we then start getting chronic changes, new bone formation. If the bone connects to the underlying enthesial bone, we call that enthesophyte, which is within the tendon, then it's the introtendon calcification. So we can also see problems with adjacent structures, such as adjacent bone might have erosions, and we can also see bursitis with these. Now, in 2013, OMRACT, the ultrasound subgroup, came up with some consensus definitions. So I know our distinguished colleagues here are all aware of what OMRACT does, but it's problematic because here are a bunch of us who are very enthusiastic and somewhat crazy. We decided to come up with a consensus definition, which sometimes does not make sense. And one of these consensus definitions was we should only strictly include Doppler signal within 2 millimeters of the bone. And this is a big problem. And one of the biggest problems is that it does not account for size of enthesis. So if you have a small enthesis, for example, a collateral ligament of a finger, 2 millimeter includes almost all the structure. So absolutely it does not make any sense. But yet it is in the literature. And when you see an area like this, this is a patellar ligament, how do you know where to put the cutoff? And why do I have such a big problem with it? I think we have to go back and ask the question, what is the job of the enthesis? So remember, the muscle comes and joins into a tendon, and then the tendon then attaches to the bone. So beyond moving the joint, what does it do? So if it was just like a steel cable, what will happen is you'll rip out your bone, or if it's like a rope, you'll rip the rope. So there has to be some mechanism of it absorbing shock. But it turns out when you actually look at the microscopic structure of tendons, the collagen fibrils are arranged in a nearly zigzag way, so it's nearly like a spring. So when you are moving, there's some give to the tendon. And similarly with the entheses we talked about, the majority of the entheses are fibrocartilaginous entheses, and these entheses do absorb shock too. And as we go forward and think about why we have fat pads in areas we do, these are also very important shock dissipation mechanisms. So all these structures have important roles in dissipating shock. So I think what we can't ignore is that there's not suddenly a force field that keeps inflammation right down to the 2 millimeter zone. We have to consider the whole apparatus. And in the last 5 years, there's also been some very interesting work on the pathophysiology in tendons. So normally when we are moving around, running around, there is some micro damage that occurs in the tendons, and these are repaired by tenocytes. And tenocytes are derived by stem cells. And again, in the last 5 years, we've discovered, yes, there are stem cells within the tendons. And normally when we're younger, our body is able to fully keep up with this small amount of damage and keep up with the tendon health. However, as we grow old, or we have metabolic factors or genetic predisposition, the tendon becomes damaged to such a point that it has to invoke the immune system. And there's some early literature now looking at triggering toll-like receptors, especially toll-like receptor 4, and then setting up an innate immune-mediated response. And where does this become interesting? So we are now in the era of really recognizing innate immunity and the IL-17, 12, 23 axis. So it's all starting to make sense as to why there's so much overlap with biomechanical factors and some of the diseases we look after, such as peripheral spondyloarthropathy and axial spondyloarthropathy. So as this process comes along, you start getting changes in the entheses, but also in the adjacent tendon. And this is a big point I want to make. You just can't ignore all the structures adjacent to it. And I think what it makes sense is that we need to be neutral. We can't just have science by consensus. We have to have science by proof. And this is the whole way of doing science. We have to say, let's do the experiment and let's see what we find. So by being neutral, we can record Doppler activity right next to a bone, and then greater than 2 millimeters, and then also look at adjacent structures in the fat pad, in the bursa. And in 2019, there are at least 3 papers who are now doing this, which are challenging our OMRAC colleagues. And so this is not new. So those of you who've been following the field very much know of Dennis McGonigal and Mike Benjamin's work on the enthesis organ concept. And this was one of the first papers that I read, and I was a real major epiphany in thinking that they already had thought about it. And Mike Benjamin was a fantastic anatomist who thought about this and eloquently put this in his papers. Okay, so now we've kind of talked about enthesitis and some of the pathophysiology, what we can see, what we want to see. The next thing is, what do we use and how do we use this tool? So I think the first interest is using it as a diagnostic tool. And I know a lot of us have a groan when we see our patients with fibromyalgia, and we're always wondering, especially with the fibromyalgia patients, psoriasis, how can I tell the difference between underlying enthesitis and something real going on, or is it all central sensitization? So I think this is one area where there's big interest, and this is one study from Marchesini et al. On the left there that looked at 30 patients, and since then they're just about to publish a much bigger multi-center study from Italy showing that in psoriasis and psoriatic arthritis, you see much more enthesitis than in fibromyalgia. And in this small study, they said you have to have signals in at least three entheses rather than just choosing one. And this goes again to the point that there is biomechanical overlay. So you just can't say, if I see, just look at one enthesis, there's activity, you cannot say that's inflammation. So you have to have at least 3 or more. And in the new study, they're proposing looking at pairs. Now, one of the big things that has come along in the last 3 years is this huge factor of biomechanical weighting. And this comes from the Toronto group's work that looked at patients with psoriasis and healthy controls. And they found that in patients with a BMI of greater than 30, you just cannot tell the difference between the groups. So BMI and biomechanical factors are huge. So now, when we are looking at all these studies, we want to look at the fact that they did look at BMI. So the next group of patients we want to look at is our psoriasis patients and figure out, can I detect early disease? Just like in rheumatoid arthritis in the last 2 talks we've been hearing, there's great interest in recognizing psoriatic arthritis early, not only because we want to treat them early and prevent damage, but also decrease morbidity. So Tinez et al. Have this paper on the left there. If you remember, those of you who follow the literature, Gisondi was a dermatologist who first, several years ago, published this cohort of patients finding that they really have occult enthesopathy going on. And 20 out of these 30 patients were then followed. And what they found was that the higher guess score predicted who turned out to have psoriatic arthritis or osteoarthritis. But at 3.5 years, when they ultrasounded them, the groups were pretty similar. There was a very fascinating study just been published from Jeddah by Al-Nedi et al., which looked at 109 asymptomatic psoriasis patients and 90 healthy controls. And they were very extensive in the ultrasound. They looked at 8 entheses, 34 joints at baseline and 3 monthly. And they found subclinical synovitis and enthesitis in up to 40% of their psoriasis patients and 10% of the controls. And at 2-year follow-up, they found that the annual incidence of psoriatic arthritis based on Casper criteria was 4.3%. and that the patients who develop psoriatic arthritis, they tended to have higher baseline scores. Unfortunately, the group did not report BMI, so we don't know how that panned out. So it'll be interesting if they go back and do that. So far what I've told you, where we're tripping on is really confounding factors, biomechanical factors, especially body mass index. In the US and North America, for us, it's a big deal. A lot of our patients are obese. And in Europe, we also have found that activity is a big problem, and I'll go over one study that shows that. Age, selection of entheses, majority of tools use lower extremity entheses, which are hugely confounded by obesity and biomechanical factors. The other problem is a lot of these studies differ number of entheses they use and the cutoffs. And we don't want to forget diabetes and hyperuricemia, which are also common in these group of patients. So therefore, there's really an unmet need in trying to figure out how to fine-tune our ultrasound instruments to account for these confounding factors. So in the last few minutes, what I'm going to do is go over some of the approaches different groups have taken in controlling for these confounding factors. So the first one was from the Dutch group. Again, if you've ever been to Holland, you know these people are very active. You have to walk everywhere, which is not America, and you have to bike everywhere. So a lot of their patients do have a lot of knee activity. Normal patients have lower knee Doppler activity, and they found this was a big problem. This is the second series of studies that have published, and they wanted to figure out a way of how to make sure that they could distinguish normal people from psoriatic arthritis patients. So they expanded some of their power Doppler scoring, but that didn't matter as much as taking out the knee completely. And so when they took out the knee enthesis completely, they were able to compare these groups using the interquartile ranges. Another approach from the Toronto group was to look at a whole bunch of entheses, compare it to healthy controls, and then do statistical modeling using regression, and then figure out which entheses are more specific. And these are the candidate entheses you look at. So I was personally very against looking at supraspinatus, but I was very surprised, and I learned a lot, that supraspinatus is actually quite specific. And it turned out the lateral epicondyle is also quite specific. And similarly, the study also figured out which of the elementary lesions were more important, and these are listed here. So this has formed the basis of our work in GRAPPA. So those of you who don't know, GRAPPA is an international organization of rheumatologists, dermatologists, people who are interested in psoriatic arthritis, as well as patients. And as part of that group, we are doing an ultrasound project in creating a diagnostic tool. And those of you who are members of GRAPPA, you should have got an email asking you to participate, especially if you're sonographers. If you didn't get the email, please catch me at the end. And we have now, with these pilot studies, have created a protocol, a working group, and hopefully within the next year, we'll be doing a international study, again, moving on the theme of our earlier speakers, collaboration around the world in trying to get a much more heterogeneous population in creating a tool that actually works across the board. And so we're working through this process, and hopefully in 2 to 3 years, we will have a nice product to show you. So I've talked to you about using ultrasound as a diagnostic tool. The last thing I want to talk to you about is responsiveness. So when you read literature, they all report the incidence of masses reduced by this amount, or spark reduced by this amount, but we never get a good idea of how meaningful that reduction is, or does it mean anything? So there's only been one study that actually reported on responsiveness of clinical endothelial indices. And this was a post-hoc analysis of peripheral spondyloarthropathy and treated with adalimumab. So there were 84 patients who were treated with adalimumab, and this was a placebo-controlled trial, 81 people on placebo. They all got adalimumab every 2 weeks. And what this study shows is that the SPARC and the LEI were much more responsive and could tell the difference between these two groups rather than the MASIs. And the question is, why is that? So if you remember, the MASIs includes things like costochondral junction, the pelvic brim, the spinous process number 5, and these are very central entheses, and these are very much more confounded by also central sensitization, whereas psoriatic arthritis is a peripheral spondyloarthropathy predominantly. So if you're giving a drug to improve peripheral spondyloarthropathy, you're going to see changes in that. And that's why the instruments that measure peripheral spondyloarthropathy were more responsive. And again, what was surprising, again, reading this literature to me, is that clinically, the greater trochanter was one of the most discriminative sites, whereas as scanners, what we notice is that the greater trochanter has a lot of degenerative change, a lot of irregularities, and the literature is conflicted. Half the literature says you can use it, half the literature says you can't. And similarly with the medial lateral epicondyle. And so these were surprising findings from these studies. So we'll have to see whether others go ahead and can replicate these results using their cohorts. Okay, so the second last slide, thank you very much. So with ultrasound, what we are interested in is, again, what changes with treatment. So obviously, things like enthesiophytes, calcification, osteoproliferation, I think all of us can agree that this is damage. It's not going to change much in terms of regression. It might get worse a little bit, but you're not going to see much responsiveness there. So I think the lesions we're looking at, and the literature does agree, is really looking at neovascularity as well as enthesial thickening and hypoechogenicity and bursitis. And this is where most of the literature agrees. And if you notice that I'm drawing these rectangles in the middle, okay, I'm not drawing them at one end showing that they're fully responsive. And this, again, is because of my biomechanical changes. So these biomechanical changes are not fully reversible, okay? So just the last slide here. So there's only been one study that looked at responsiveness to enthesitis thickening by ultrasound. And this was a study by Litinsky et al. That looked at 43 psoriatic arthritis patients, 19 on methotrexate, 24 on adalimumab, and they did ultrasound at baseline 3 and 6 months. And it was curious that they measured some of the hand entheses, flexor and extensor tendons, at the second and third fingers, as well as plantar fascia and Achilles tendon. And essentially, the adalimumab group had improvement in all these entheses. So I would just summarize that the systematic reviews do seem to agree that the components of ultrasound elementary lesions that are responsive are hypoechogenicity, enthesial thickness, and Doppler. So in summary, I hope you've seen an interesting journey that I've taken through this field, asking very basic questions as to what are entheses, why do we get enthesitis where we get it, and also now recognizing huge biomechanical confounders as we go forward, and some of the things that we are doing to account for them in creating this instrument that will help us differentiate. Thank you so much.
Thank you very much. We have a quick question. So if anybody has a question on the really interesting session, actually I would like to drop listening to many things that we learn more about that. So anybody who has any question about the first session, rheumatoid arthritis, updated Saudi Arabia, and the second one, free revision, because real life practice in Kuwait, and the last speaker also for the Yes, you have a microphone? You cannot hear me. Or you can approach us. With your microphone. If you have any question, please. Please your name and your
محمود سعيد من سكاكا الجوف مستشفى الأمير متعب. السؤال يعني من يوم ما اشتغلت when I started working in Saudi, I didn't find leflunomide. One of doctors say because pregnancy and repeated pregnancy, they prevented it. Is it a guideline or just يعني اجتهاد شخصي personal؟ ها؟ I asked it many times. It is not available in governmental in our area. Thank you. سؤال is ultrasound can show any difference in scleroderma? Any skin changes can be detected by ultrasound?
Thank you so much for the question. So there are studies that looked at ultrasound use in the early scleroderma. So you can actually measure the thickness of skin quite well. The frequency of the probes now available, you can go up to anywhere from 22 megahertz to 60 megahertz. So the skin actually is a huge interest, not only to us but also to dermatologists for different diseases. But beyond that, I think much more interesting for us dermatologists is the musculoskeletal system. So just last week, I had a patient with scleroderma with acute ankle pain, and she had tibialis anterior tenosynovitis and synovitis in the ankle joints. So very, very interesting that we can actually pinpoint exactly where the problem is. And then if they're very symptomatic, we can try to give very local corticosteroids. Again, with systemic sclerosis, we're always afraid to give them systemic steroids. It is acute. So it's a tool that we can help you with that too.
Next question.
Okay, thank you. My question, Oshe, thank you very much for all the speakers. Excellent talk. Thank you very much. My question is for Doctora. Do you now, in your practice in rheumatoid, if they are ACCP negative, do you try to stop your DMARDs? Do you wean them off?
Thank you for the question. Can you hear me?
Can you fix the mics because we're having trouble with the mics?
Can you hear me? Actually, we don't have special guidelines in Kuwait as in the other countries, but I personally, and I think a lot of rheumatologists would agree with me, that if the patient has been in remission for a long time, first the patient will do it, whether you're going to advise him or not. He's going to try to taper his medication and try to stop it because he's doing very well. So what I personally do is that I tell the patient there is a risk, maybe 50%, maybe more, that you're going to relapse, and there is a risk that it will be difficult for you to be in remission again on that treatment again. But there is a good chance that you may, that we may taper down your medication and stop your medication. However, what I do is that I select the patient. The patient has to be smart enough. So if he starts to get any symptom, then he should go right away to his medication. So I personally do it. I taper down the medication, but most of the rheumatologists would agree that it will be difficult to stop the medications, but at least taper down the medications.
You're not worried when you restart they will become resistant to treatment? Is that an issue?
Actually, yes. I get worried. Most of the rheumatologists get worried for that reason. But the patient should know this. And if he agrees, well and good, we might try it. And then if this medication doesn't work, we can try another biologic.
Thank you very much.
But I think it's worth it.
Any more burning questions? Professor Susan.
Assalamu alaikum. First of all, I would like to thank all the speakers. It's a great pleasure to have all of you, and the quality of the lectures were excellent. My question actually is for Prof. Hanin Muallim. I enjoyed your registry, and it's always a good start to have such a registry in order to guide us what to do next. My question to you is with regard to the most common comorbidity, which is osteoporosis that you find. Now, the majority of the patients, they are middle age. So I presume that, that you did a further analysis of the data, and those osteoporosis were mainly in above 60, or there's like a younger population in our registry?
We are working on further analyzing the data. This is one of the small projects that we can run through the registries. But again, Prof. Sudan, I don't think our data will be so much reliable if we went on a specific question in even 600 number of patients is not small, but to give a clear answer about your excellent research question, I think we need multiple centers. Probably when we join us in the registry, we can run this question together.
Inshallah. Thank you so much again.
Great. Any more questions?
Yeah, one more. Assalamu alaikum. My question is to Dr. Gurjit. Since rheumatoid arthritis or psoriatic arthritis, these are considered to be systematic diseases right now in a larger perspective. So are there any specific entheses which we should look in ultrasound rather than looking at all the entheses? Since we walk, we run, we do all the activities, so we will have minor change in all the entheses. So are there any specific entheses to look for?
So this is the research question that we're addressing. So it looks like amongst the large entheses, the supraspinatus, lateral epicondyle, the knee enthesis, Achilles tendon and plantar fascia are the leading candidates right now, as the entheses will pick. But again, this will get sorted out in the next 2 to 3 years as to what are minimally confounded. And in parallel, we're also looking at small entheses of the hand. And there's some very interesting literature in the last 2 years looking at A1 pulley, A2 pulley thickness, as well as flexor tendon thickness. And not only are they thickened, more thickened in psoriatic arthritis patients, but they also seem to be, especially the flexor tendon thickening, somewhat responsive. So I think the research agenda is rich, and it's going to be exciting to figure out the correct set of entheses that are ideal for these patients.
Great. I think we'll end the Q&A session now, and I'd like to thank our speakers for sharing their experience and knowledge and delivering a great important message. Thank you so much, and I think we'll head towards the symposium.